Now still two parts of station 4, very important parts. I should do clockwise rotation to see the left kidney, left suprarenal. Yes, this is the left kidney and left suprarenal. And to see the spleen when I do clockwise rotation. But the most important point, I should start doing clockwise rotation. I start doing clockwise rotation when I see the splenic vessels, the splenic artery and splenic vein, and put them in the middle of the screen. By then, I start doing clockwise rotation. Let us see this video. This is again the abdominal aorta, and this is the celiac axis, and this is the splenic vessels. This is splenic artery coming from the celiac axis and the splenic vein. Now I moved the echo endoscope inside. I pushed it forward to locate the splenic vessels in the middle of the screen. By then, here, this is the level of the pancreatic body. The level of the pancreatic neck is at the venous confluence, exactly. And the pancreatic body is at the level of the splenic vessels. Here, the splenic vessels are located in the middle of the screen. Then I can do now clockwise rotation, pancreatic body. This is the pancreatic body. And here, still the splenic vessels, and here coming the left kidney. And there is a small angiomyolipoma, a small benign hamartoma, accidentally seen in this left kidney. Yes, and this is the left kidney, very nicely seen, the sinus and the parenchyma. And here, this is the left kidney. Here I can see the left suprarenal gland. This is the region of the pancreatic tail. At the level of the kidney and left suprarenal, this is the anatomical site of the pancreatic tail. Okay, yes, this is very nicely seen, left suprarenal glands, and this shape is like also the seagull. So this is the fourth seagull which saw today. Okay, and more clockwise rotation, and I can see the spleen. So, yes, and here's a part of the pancreas in between the spleen and the left kidney is the tip of the pancreatic tail. So to revise again, the neck of the pancreas is at the venous confluence of the splenic, superior mesenteric, and portal. The body of the pancreas is the level of the splenic vessels, and the pancreatic tail is the level at the left kidney and left suprarenal, and the tip of the pancreatic tail is interposed between the left kidney and the spleen. So this is the clockwise rotation. Coming to the last part of station 4, which is anti-clockwise rotation. I start doing anti-clockwise rotation at the level of the splenic vessels. I should locate the splenic vessels in the middle of the screen. Now I push the echo endoscope very nicely. Now it is in the middle of the screen. This is the splenic artery and the splenic vein. And this is the region of the pancreatic body. Now I will concentrate on the splenic vein. Don't push or pull. Just do anti-clockwise rotation. Sorry. Just do anti-clockwise rotation. Yes. Locate the splenic vessels in the middle of the screen and concentrate on the splenic vein. Now anti-clockwise rotation, very nicely, I went to the confluence of the splenic, superior mesenteric, and the portal vein. Here, this is the region of the neck of the pancreas, or the genome of the pancreas at the venous confluence. And here, this is the pancreatic head. So this is the pancreatic head, and this is the pancreatic neck. And this is the portal vein going to the liver and the superior mesenteric vein. Here, the superior mesenteric vein is the nearest structure to the echo endoscope, opposite to that in station 3 of the duodenum. And expecting to find the common bile duct here, this is the farthest structure from the echo endoscope, opposite to that of the duodenum. Expecting to find the common bile duct here, going to the region of the papilla, and this is the lumen of the second part of the duodenum. seen from the stomach. So from the stomach, I can see all structure. I can see the pancreatic head. I can see the pancreatic neck. I can see the papillary region. I can see the whole length of the common bile duct going back. Really, it is at the beginning, it is difficult to follow up the common bile duct from this situation. But after the 10 patients or 15 patients, it will be much more easier, and we will got the momentum of examining the whole intra-abdominal structures from the stomach. So let us continue this video. Yes, this is the superior mesenteric vein. Okay, and this is the head of the pancreas, and very nicely seen here the common bile duct. This is the common bile duct going to the papillary region at the lumen of the second part of the duodenum, all that seen from the stomach, and expecting here that the pancreatic duct is always in between the superior mesenteric vein and the common bile ducts, expecting to be here and going to join the common bile duct as the papillary region. So let us continue this video. Yeah, this is the common bile duct, the whole length of the common bile duct, air inside the second part of the duodenum, and expecting here to find the pancreatic duct joining the common bile duct. Yes, appearing here. Yeah, starts to appear. This is the pancreatic duct joining the common bile duct. Yes, this is the common bile duct. And this is the pancreatic duct. And this is the venous confluence. And this is the papillary region. Yes, here it is very nicely seen. This is the common bile duct. And this is the pancreatic duct joining each other at the region of the papilla. And this sign tell us that there is no pancreatic divism. The main pancreatic duct is normally joining the common bile duct as the region of the papilla. Okay. Yes, 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 joining each other at the region of the papilla. Yes. And here, this is the venous confluence. And here, the whole length of the common bile duct. To be sure, we will apply Doppler. The vascular structures will have a color flow signal like the superior mesenteric, but here the common bile duct and the pancreatic duct, no signal inside. Let us see some funny videos. This is a pathological lesion seen in this station. Yes, are now in the same station. And this is the superior mesenteric vein. And this is the pancreatic head. And this is a very wide structure. No signal inside. Actually, this is dilated common bile duct. It is seen dilated. It is, I think, more than 1.5 centimeters. So it is pathological dilatation of the common bile duct, and this is the pancreatic duct. And this is the superior mesenteric vein. What is the region of dilatation of the common bile duct? We can trace the whole length of the common bile duct in this station in a trial to know the cause of pancreatic, dilatation of the common bile duct. Here, it's appearing that is a structure. There is a structure inside the common bile duct, the mid third of the common bile duct. Here is the distal third of the common bile duct. Very nicely seen, an echogenic whitish structure with dense posterior shadowing. So this is a large stone inside the mid common bile duct, and of course it is the cause of common bile duct dilatation. It is a moving stone in the common bile duct down and forth with bile duct dilatation. This is another video from the same station, but it is a distal, large distal common bile duct stone, impacted stone as the region of the papilla. This is the common bile duct, hugely dilated common bile duct with a stone, a large stone impacted in the region. This stone was interpreted by MRCP as a soft tissue mass because MRCP has fallacies, about 10 to 15% false diagnosis, especially if there is impacted stone. If it is floating stone, it is very easy to be diagnosed by magnetic resonance cholangiopancreatography because it appears as a focal defect. But when it is impacted in the papilla, it appears as a soft tissue area, interpreted as a soft tissue mass. But here by the endoscopic ultrasound, very nicely seen that it is a stone because it is very echogenic, very well defined with a dense posterior shadowing. And of course, ERCP proved the presence of a large stone in the common bile duct. It is impacted in the distal part of the common bile duct, and all these structures are seen from station 4 of the stomach. This is a very nice case and very interesting case of a young female with CBD dilatation, and there is a large papillary mass. This is station 2 as the region of the papilla. Station 2 at the region of the papilla in the mid-second part of the duodenum, appearing that this is a very nicely seen large papillary mass, and this is stent. It is stented, and unfortunately, biopsies by the duodenoscope was inconclusive, just duodenitis. And here, examination from the stomach. Yes, examination. Stop this video. Examination from the stomach. I can see the superior mesenteric vein, and this is the, yes, this is the papillary mass, and this is the second part of the duodenum, and here the common bile duct is collapsed over stent. Common bile duct is not dilated because there is a stent inside and there is air inside. And here at the region of the papilla, I can see a large papillary mass. This is the venous superior mesenteric vein. This is the aorta and inferior vena cava, and this is the head of the pancreas. And here I can see very nicely large papillary mass and a stent with air inside the well decompressed common bile duct. FNA was done, and of course it was done while I am in the duodenum, because here the needle can pass easily to the mass. It is very near to the lumen, while here the mass is away from the echo endoscope. I should travel a long distance through the pancreas to reach the mass from the stomach. And passing through the normal pancreas carries a high risk of pancreatitis. So it is a large papillary mass, and this is the stent, very nicely seen, plastic stent with air inside, well collapsed common bile duct seen from the stomach. And surprisingly, the patient, this FNA was done, and the cytology suggested gastrointestinal stromal cell tumor. It is very rare, but can occur in the papilla. The patient was sent for surgery, and the final histopathological examination proved that it is a GIST tumor, gastrointestinal stromal cell tumor. Now we finished examination of station 4. It is a long station, no doubt, but very nice, very informative, somewhat difficult at the beginning, but after applying these techniques for many, many patients, I think after 10 to 15 or 20 patients, you are all will mastering this technique. It is very nice because it gives us very nice information about the intra-abdominal structures, and became very important examination. Why? Because if there is gastric outlet obstruction, whether benign, due to benign causes as peptic ulcer disease or malignant causes, so you can't go to the duodenum. So you should do the whole job from the stomach.